Hello, everyone, and thank you for joining us on our second My Bones webinar. So it's very exciting that we have some wonderful guests with us today. So we have Professor Clinton Rubin with us, all the way from the US. So for those of you who don't know, the professor is a SUNY distinguished professor and the director of the Center of Biotechnology at Stony Brook University in New York. His work is mainly centered around understanding the cellular mechanisms and mechanical stimuli responsible for bone growth and health. So partly in collaboration with NASA, Professor Rubin researched and developed low intensity vibration therapy used in the Marodyne device here today. So the professor holds more than 30 patents in the areas of wound repair, stem cell regulation, and also the treatment of metabolic diseases. And he's published over 3,000 articles, and I stand corrected today that he's been cited over 39,000 times. So it's an awful lot, and it's an absolute pleasure to have the professor with us here today. And also alongside, we've got Dave Crucifix. So Dave is a former research scientist with Kodak, and his specialism is taking technical subjects and translating them into a really easy everyday terms so that people like us can understand. So he's also using the Marodyne LiV device to help with his CMT. For those of you who don't know, that's Charcot-Marie tooth disease. So he knows a lot about the device, using it daily. I should probably introduce myself as well, forgot about that. So I'm Leah, I work here at My Bones, I'm the business manager, and this is George as well. I know that last time we did a webinar, we didn't introduce him, so it's a bit weird that he was just sitting there, but now he's got a name. So we're going to have some discussion between the professor and Dave, and then we'll move on to some Q&As later on. So thank you for everyone who's already submitted questions. There's some really wonderful questions out there, so we'll get hopefully through as many as possible later on. But yeah, keep submitting. There's a chat box down the bottom and also a Q&A section, so by all means keep going. So without further ado, I'll pass on to Dave and he can start with the questions.
Good morning, Professor. One of the first things I'm interested in is how low intensity vibration therapy improves bone density and the muscle strength. Can we go through some of the techniques of how this vibration actually affects the mesenchymal stem cells?
Sure, and thanks for the invitation to participate in this webinar. And Leah, thank you for the kind introduction. Just in case my mom is listening, I want to make sure that it's published over 300, not 3,000 articles, if only, but otherwise all good. So Dave, back to your question about why vibration and how could it possibly influence the musculoskeletal system. For those of you who are kind enough to listen, one of the signature features of the musculoskeletal system is that it responds to mechanical signals. And we typically think of mechanical signals as being things like exercise, sort of the old, at least in America, the adage of use it or lose it. And a good way of thinking about that is that on the positive side of the equation, and specifically in terms of bone and muscle, you can think of weightlifters, Arnold Schwarzenegger lifting up lots of weights and he has big muscles. But the thing that you don't really see, but has now been measured, is how that influences bone. So in professional tennis players, think of someone like Venus Williams, the professional tennis players have about 30 to 35% more bone on their playing arm than they do on the arm that throws the ball into the air. So that's a sort of an index that somehow the bone cells living in the skeleton, in your bone tissue, can perceive and respond to these mechanical signals. The thing to bear in mind is there's a downside to that as well. As Leah pointed out in her intro, much of the work that we have done over the past 35, 40 years has been funded by agencies like NASA to understand why it is that astronauts lose bone so quickly. So when we think about osteoporosis, we as earthbound humans tend to peak our bone mass at the age of around 35. And then every decade after that, we lose 2 to 3% of our bone. Women, for right around the menopause and following the menopause, lose 2 to 3% of their bone per year. Astronauts are losing 2 to 3% of their bone per month. So what is it about astronauts, these heroes that are brave enough to go into space? What they're missing is gravity. And so that's evidence, just like laying up in bed, or if you're injured and in a hospital, or if you're a couch potato binge watching Netflix all the time, without those mechanical signals to your skeleton, your bone will actively resorb away. So your and my skeleton is a balance between the mechanical challenges that are put on it and our ability to form bone.
So it's fair to say that the human skeletal system is a smart system. It responds to activities that are placed upon it. Why? Surely the muscle movement is a smooth movement rather than a vibratory movement. Why do we aim at 30 hertz? And
it's a great question. So, we tend to think of walking as 1 cycle per second, or 1 hertz, and running at 2 cycles per second, 2 hertz. But the vibration that we use in our clinical trials is all around 30 hertz, 30 cycles per second. And what conceivable physiologic relevance could that have? And it turns out that your muscle, even though it contracts as you pick up your coffee cup in the morning, or maybe a beer in the evening, is that even though it's relatively slow movement, that your muscle is really an inefficient motor. And the way that it contracts is it's actually shaking very, very subtly, but shaking as it pulls up and you drink your sip of coffee. And it turns out that adult musculature vibrates or shakes between 20 to 50 cycles per second, 20 to 50 hertz. Okay. And so what we're doing with the low intensity vibration is providing a surrogate for that muscle contraction.
And why at such a low rate of gravity? I mean, I'm presuming that if I was to walk along the road, I would be impacting at maybe 1 G, I guess. And
right.
We're looking at less than 1 G here. Is there a specific reason?
So again, what we're not trying to fool Mother Nature or reinvent exercise. We're trying to provide a surrogate for exercise.
Okay.
So if you look at what you and I might do over the course of the day, is we might walk down the hall, maybe we'll go for a walk in the park, play a little tennis or something. But the predominant activity that we do in sort of modern society is sit around, do Zoom calls or listen to Zoom calls, that sort of thing.
Yeah.
So what your skeleton really is seeing is not this impact of 1 G, that Earth's gravitational field, which will become very important in our discussion. So Earth's gravitational pull, what tugs us to the ground, is 1 G. You might remember from high school physics, 9.8 meters per second squared. As you walk along, the impact spike of your heel on the ground is around 1.2 G. So why is it we're delivering with our low intensity vibration 0.4 G, or essentially 30% of what you might see during walking? Then in reality, that envelope of vibration, that 10 minutes of standing on a device, which we ask for, is overall much greater than what you might see from muscle delivering a vibration signal to the skeleton over an 8-hour walk. So we're trying to sort of compress a lot of mechanical information in a very safe envelope to the skeleton to make it think that it sees a lot of mechanical demand. So we're putting exercise in a bottle, as it were.
Exercise is a pill almost.
Right, almost, but not quite. We're not there yet.
And am I right in understanding that these vibrations that mimic the vibratory nature of the muscle actually influence the stem cells to change what they're going to become? Rather than becoming fat, they grow up to be bone.
Sorry.
I was going to say, and how does that compare with pharmacological treatments for osteoporosis and bone issues?
Okay, so there are two very complicated questions. I'll see if I can tease them apart. And,
okay.
Because your job is to make sense of what it is that I say.
Right.
Please feel free to chip in. But let's deal with the first chapter of your question, which are these stem cells. So in everyone's bone marrow, yours and mine, and people who are quite young and people who are elderly, have these pluripotent stem cells sitting in the bone marrow called mesenchymal stem cells, because it's a bit of a tongue twister. Those of us in the bone world call them MSCs. And these MSCs, because they're pluripotent, they can grow up or differentiate into many different cell types: bone cell, muscle cells, actually satellite cells becoming muscle cells, ligament, tendon, but also they can become adipocytes or fat cells. So imagine you're this cell sitting in the marrow trying to figure out, what am I going to do when I grow up? And what they take is they take cues from their environment in the marrow. They may take hormonal cues, but they also take physical cues, mechanical cues. So an MSC sitting in your bone marrow, it's trying to decide what sort of cell to become when it grows up, sees a lot of activity. And just as you pointed out, the bone is a very smart material. It needs to grow to withstand the loads that are imposed upon it. That it perceives these mechanical signals and says, aha, I should become a bone cell. Alternatively, going back to the couch potato scenario, that mesenchymal stem cell without these mechanical cues says, nobody needs me, I'm going to become fat. And that's one of the many reasons why people who are less active tend to generate a lot of fat around their midsection, subcutaneous and visceral fat, but also fat in the bone marrow, which is also important in our discussion because as we age, our marrow has fewer and fewer of these stem cells around. So you really want to try to recruit them early. And just before I lose my train of thought, the other things that mechanical signals cue into are the existing or the resident bone cell population, osteocytes, which are embedded or entombed within the bone tissue, and the bone lining cells that become osteoblasts. So there's this whole sort of interconnected synthesis of mechanical signals and perceiving them and responding to them. The other side, the other part of your question about pharmacologic or drug treatments for osteoporosis, there are certainly, very, very good drugs out there. I know there are a lot of people who don't want to take drugs to prevent a disease. I happen to be one of them. But that doesn't mean that they don't work. And they typically work in two different pathways. Okay. They're anti-resorptive drugs, which stop osteoclasts, the bone-eating cells, and they're anabolic therapies that stimulate bone cells to grow bone. But I will point out that these are systemic treatments for disease, which is really symptomatic, really at the hip and spine. So the consequences of drug treatment is whole body, while the benefits are very local.
Right, and it's so in layman's terms, effectively, we're giving the stem cells a nudge in the right direction to do what we want them to do. If we were taking a pharmacological tactic, that would be acting over the entire bone structure. Whereas by using the vibration therapy, we're concentrating it more in the areas that we want and the load-bearing areas. Would that be fair to say?
Right. I mean, going back to your metaphor of being a smart material, you think of your femoral neck or your thigh bone where it reaches your hip bone, the pelvis. That femoral neck is holding up your entire weight-bearing structure. Yeah. So as you're walking or as you're vibrating, there's really markedly high signals in the femoral neck. And if you imagine that the bone is adapting to the challenges as you are vibrating or as you're walking, those trabeculae, the struts in the femoral neck, see the signal, adapt, become thicker, and by that measure actually reduce the challenge that's on there. So it is tuning itself to the demands that are made.
Okay, so we're making use of the smart facilities and triggering the right build processes for us. We always talk about 10 minutes a day using low intensity vibration. Is there any benefit in doing more than 10 minutes a day, or can I split it up, or will it work in conjunction with some other exercise?
Right, so that's a great question. I'm going to answer it in a whole sort of number of different why we chose 10 minutes, why maybe more than 10 minutes isn't necessarily useful, and why breaking up the signal is maybe perhaps even better than doing one dose of 10 minutes per day. Okay. So the 10 minutes sort of stems, no pun intended, from the earlier discussion of putting all of this mechanical information in a very short period of time. We're basically trying to represent extremely small vibrations from the muscle that might be seen over the course of a day. We're trying to compress them in safely into a 10-minute period. So that 10 minutes is meant to represent what muscle is doing to your skeleton, weight-bearing skeleton, over this entire 8-hour period. So even though they are small, they're much, much larger than what muscle generates. So that's where the 10 minutes comes from. Now, why 10 minutes? What we also want to do, if I happen to be vibrating cells or in a preclinical model of bone disease in mice or something, my cells are very compliant. They do exactly what I ask them to do. But the most difficult science that we've ever done in our lab group is translating it to the clinic, sort of bench to bedside. Can we do clinical trials on vibration and show efficacy? Can it work? And the problem is that people out there, as well-intentioned as they may be, some are more compliant or follow the rules better than others. Some, might cheat a little bit. Some might want to skip a few days, et cetera. So what we found is 10 minutes is just enough to not really sort of get in the way of your daily activities. Okay. Like I said, stand on this for an hour per day. You might do it for a couple of days, but after that, forget about it. So you can stand on this device while watching TV, talking on the phone, reading a book, that sort of thing. And so what we find is sort of a sweet spot for people to be responsive. And I would say the younger you are, and by younger, I mean 20 or 30, because you have more stem cells, they are more responsive. You could probably cheat a little bit and go a shorter time, but I'm not suggesting that. But back to breaking it up. From a cell biologist viewpoint, what happens is that these cells in your body that are being mechanically challenged, the very first thing they do before they start producing bone is they themselves adapt. Just like if I suddenly put a bright light in your eyes, that you would instantly adapt to that, right? If I started shouting at you, your ears would instantly adapt to that. Bone cells are the same way. They begin to transiently, over a short period of time, change their phenotype or change the way that they are put together. What we find is this stem cell and also bone cells is they change their architecture such that the structures that pick up mechanical signals are more robust. So if you stimulate your bone cell and it becomes more robust, and then stimulate it again in a couple of hours, there are more receptors and structures that can respond. So it's a way of ratcheting up the response.
Is this where I've heard the phrase turning the light bulb on? Is that what we're talking about here?
Right. So what we found, and I think it's still a little up in the air, but what we found with mechanical signals is it's not necessarily a graded response, but rather like turning the light switch off on in your room, right? When you walk in the room, you turn the light, but all of a sudden, all the lights come on, not just some of them, and then over time, more and more and more. So what we find, if you can trigger the cells to adapt,
right,
that more isn't necessarily better. The lights don't get brighter. The cells are working as hard as they can. So back to your question about a couple of times per day, it's like it's enables or allows for a second switch to be turned on. So another set of lights turns on. So you're absolutely right. Turning on the lights in a room is mechanically activating cells. And remember, it does go the other way, that if you're active and the lights are on every day and that's all good, and then you decide, forget about it, I'm done with exercise, the lights will go off and will allow and be permissive to the bone-eating cells, these osteoclasts, to begin to break down the bone.
So when we use low-intensity vibration, we need to have a regular pattern of using it, I presume. So it would be no good, for instance, doing 5 days a week and having the weekend off, because my light bulbs go off at the weekend.
Right. I mean, to take it a little more extreme, that a number of people really from around the world, and you know, I'm really excited that our work is reaching around the globe. They wonder if, as you point out, 10 minutes per day, across a week, 70 minutes. So can I just avoid Monday through Saturday and just on Sunday stand on the device for 60 minutes or 70 minutes? It doesn't really work that way.
Okay.
Because again, you've turned on the light switch with your 10 minutes. The additional period of time it's not money in the bank. And then by the next day, because it is transient, your cells become more couch potato-like. And by the time you wait till the end of the week, they're essentially just lazy old fat cells. So yes, absolutely. If you aren't interested in low intensity vibration, that's fine, but you need to exercise every day. So those that tell you, oh, just go to the gym once or twice a week to build up your skeleton and your muscle, it's just not true. The more, if you could get to 7 days a week, great.
So really, we don't need to do a long period of time, but we need the regularity to keep that system running and building.
Right. It's just, you know, think of how we evolved as vertebrates or evolved as humans. Really, we were out active, whether we were, you know, hunting or gathering vegetables. We were very, very active as we grew up in the world. And it's only sort of modern society that allows us to sit around and watch webinars. And so your skeleton is really tuned to sort of, you don't want to build up your skeleton so much if I'm out in the wild that it's so robust that I can't run away from predators. But then I also don't want it to break when I step in a pothole, right?
Yeah.
So it is evolved to be this smart material optimized structure.
And let me just check that I'm understanding this right. When we use the low intensity vibration, the vibrations are transmitted through the body, through the weight bearing skeleton. Do they have any impact, the vibrations, on, say, the forearms or the hands or any of the other bones in the body, or is it concentrated in that weight bearing structure?
Right. It's a great question. And I wish that it was a magic bullet or a magic drug that would systemically treat osteoporosis. But remember, first, let's all remember, if you're tuning into this, you probably already know, because of your interest in osteoporosis, that where it's really sort of tragically symptomatic are fractures of the femoral neck or collapse of the vertebrae of the spine. And this is really why things like dual energy X-ray absorbed geometry, DEXA, or CT scans as diagnostics for osteoporosis don't as much focus on the ultradistal radius, although Colles fractures, you know, falling down and stopping yourself can cause fractures of the radius. It's really most important in the hip and spine, but standing on the device the transmission, as you point out, how the vibration moves up the skeleton, is really focused first at the hip and then the spine. And by the time it reaches your head or your arms, it pretty much disappears. So I guess in a protected answer to your very, very relevant question is when we do our clinical trials, we have a paper coming out on Duchenne's muscular dystrophy, I think this week, where we actually use the wrist as an intraperson control, right? That we say vibration isn't reaching the wrist and it is reaching the hip and spine. So we compare the wrist to what's happening in other regions of the body.
Okay, that's taking a different route. I'm using the platform every day. If I stand in a different way, or I stand on one leg, or crouch, or is there any benefit or any deficit in doing any of that, or should I just literally stand as I would normally stand?
Yeah. So my advice would be, all of the things that I'm telling you and your audience about are really based on our clinical trials. I hate to extrapolate to things that we haven't necessarily studied.
No,
but the device that we're talking about here, the ones we use in our clinical trials, use what's called negative feedback loop. It has a little transducer on it that sort of determines that, oh, you weigh 145 pounds or whatever you use in England, 15 stone or whatever, sorry, England, or that I weigh 160 pounds. It's smart enough to figure out that you are different than me, and it will actually accelerate you in a way that is optimized for you versus for me. If you stand on one leg, then really what you're doing is you're only challenging that limb and not the other. So I would say a relaxed stance, fully weight bearing, no bent knees, but you don't need to stand like a Buckingham Palace guard, but just relaxed stance. And just as I said before, the vibration is so subtle that you can read or you can watch TV. It's not like, going crazy. That said, if you bend your knees, we talked about transmission, that the signal is so small that it really depends on the shin bones, the tibias, transmitting across your knee to your femur, from your femur to your pelvis to the spine, because that the hip bone is connected to the knee bone, as the old song goes.
Yes. That
once you bend your knees, the signal actually attenuates and goes away. So if you stand on a device, you can tell that it's on by putting your teeth very gently together, and you can feel them sort of chatter. But if you bend your knees, because all the energy is dissipating, no signal reaches your head whatsoever.
Okay, that makes perfect sense. So in effect, a comfortable, relaxed stance with your legs straight, or as straight as you can. Right,
so shoulder width apart, relaxed stance, just as you might if you're waiting in line to get tickets for the movies. The plate is smart enough, people shift their weight a little bit, but there's no reason to think you need to do exercises or anything like that, because if my wife uses the device every day, actually she's a devout runner, and for reasons beyond me, she says that it makes her knees feel better, but she stands on it religiously once per day. And she basically watches TV when she does it, and she doesn't really move around. She just makes it as part of her day. She's happy to do it, and end of story. She doesn't try to complicate it by lifting weights or doing push-ups on the plate or anything crazy like that.
Thinking, LiV is treated as a whole body vibration therapy. And I personally find it very beneficial. It seems to improve my blood flow. I know it may not necessarily be intrinsically designed to do that, but it seems to. What are the differences between the LiV devices and other vibrational devices I've seen?
Right. So it's a critical question, and if you stick with me, I'll try to avoid physics as much as I can. Remember we talked about Earth being 1G. Just keep that in your head. And the Marodyne LiV device is 0.4 G, right? 40% of Earth's gravitational field. And there's a global advisory for human exposure to vibration. It's called International Standards Organization, or ISO 2631. You can Google it and it'll tell you all about vibration in the workplace, because vibration is primarily studied as a pathogen. It causes low back pain, it causes circulatory disorders, white finger disease, it can cause percussive injuries to the brain. It's nasty, nasty stuff. But that is primarily from long occupational exposures to it, like driving, being a truck driver or a helicopter pilot, being somebody who uses handheld machinery, and the vibrations are quite severe. And so ISO 2631 is a great advisory for people to understand that just because LIV may be beneficial to you, more isn't necessarily better. Just as your doctor may tell you to take an aspirin per day to help minimize heart disease,
when we're saying
often take 40 aspirin per day.
Forgive me for interrupting you there, but when we're saying more isn't beneficial, what we're meaning is more aggressive vibration.
Right. So let's talk about more aggressive vibration, or devices you may see in your gym. So you go to the gym and you say, oh, I heard this My Bones webinar on vibration. There's a vibration device over there. I think I'll give it a try. The devices you see in gyms are just absurdly high in terms of magnitude of vibration. The ones that we study in terms of looking at safety can be at the low setting at 8G, or 8 times Earth's gravitational field. And at the high setting can be above 15G. Your skeleton, quite simply, or your body for that matter, just does not evolve to deal with vibrations of that magnitude. But don't take my word for it. Look at ISO 2631. Where they give sort of the margins or the thresholds of human exposure. Devices of that magnitude aren't even registering on ISO 2631 for 10 seconds of exposure. So these are 40 or 50 times greater in magnitude than the devices we use in the clinic. And the instructions, and please do listen to the instructions, say that if you are silly enough to try these devices, to bend your knees. Because if you straighten your legs, remember we talked about transmission, all of that signal will go to your head and cause potentially percussive injuries to your brain.
I presume by bending the knees, you're bringing the muscles into play and building in some suspension, which is isolating.
Right. So essentially, you're serving as a damper by bending your knees. But remember, there's no such, we say in America, no such thing as a free lunch. That if I'm going to take 8 or 10 Gs, and I want to save my brain from shaking like crazy, so the manufacturers say bend your knees, that energy has to go somewhere. To a certain extent, yes, your musculature is dampening it. But now that you've taken your tibia and your femur and you've bent it and you're vibrating up, where does that energy go? It goes to the cartilage in your knee. So imagine all of the athletes you know that complain about damage to their knee from a lifetime of activity, and compress it now into 30 minutes. Your cartilage just cannot deal with 10 Gs of impact. So whatever you do, from my view, my perspective, whatever you do not stand on those devices, period.
That's very clear advice, and I'm sure we'll all take that on board. I'm thinking around some of the things you've said. You've certainly said that in younger people, there are more stem cells available. And by using LIV, we can trigger the stem cells. Using LIV in children with certain conditions, would it be beneficial?
Right. So it's a great question. It's phenomenally interesting to me from a basic science perspective, because at the end of the day, I'm a scientist.
Yeah.
I'm not a clinician, but the most responsive clinical trials that we have done have been in kids. We've done studies on young girls with idiopathic scoliosis. We've done studies on kids with cancer that has passed, cancer in remission, to the point that it showed enough of a benefit that we're now currently doing a study on kids with active cancer. We've done studies on kids with cerebral palsy. As I mentioned earlier, we've just are publishing now a paper on kids with Duchenne's muscular dystrophy. So these are diseases that are not diseases of the skeleton per se.
Okay.
The bone cells and the stem cells are still there, and they're waiting for someone to tell them what to do. But because these kids are may not be as active, they're not in the playground, running around like most kids might be, that their stem cells are becoming sort of differentiating into fat cells, et cetera. One of the complications of many diseases is subcutaneous and visceral fat accumulation. Or high BMIs, as some people might say.
Yeah.
So we've shown in these studies that the juvenile skeleton is very, very responsive to LIV, which is really exciting to us. We've shown in some of these studies a response to the muscle as well as the bone, which is also very exciting. And we've shown in some of these studies a suppression of fat. So because you're driving these stem cells to become bone, what they aren't becoming is they aren't becoming fat. Right. So there is this sort of deal that by driving towards a bone or a muscle endpoint and not fat, that you end up with a robust skeleton and hopefully a robust musculature and not as much fat. So it's exciting. I will also point out, particularly parents who might be listening and wondering about whether it's appropriate for their kids, of course, first speak with your physician about this. But we have never, in any of the clinical trials that we have published, and we've published many of them, from kids with really disabling disorders up through the frail elderly, we have never had to report a serious adverse event, which I am very, very proud of.
So LIV, in fairness, would be beneficial to all ages, from the youngest to the eldest, unless, is there something?
I would take that with a bit of a grain of salt. I would say, although we have never studied a group of healthy young adults. So if I were 25 to 35 years of age, absolutely healthy and absolutely active, and I had a robust stem cell pool in my bone marrow and lots of osteoblasts to produce bone, what I would do if I were listening to this webinar, I'd say, the message here is to be active 7 days a week. And I probably don't need LIV because I'm sending the skeleton anyway. Remember, from our view, we are providing a surrogate for exercise. So if you can't be as active as you were, or you don't have the same stem cell pool you used to have, this is a way of tricking it into thinking that you're still an active 25-year-old.
Yeah, that's part of the reason why I use the device myself. I have muscle wastage in the lower legs, so I'm not as active as I used to be. And I use it to supplement that activity. I can still walk around, but it's beneficial to me.
So it's that you're exactly the sort of person that we want to reach out to and ideally connect to. That this is, again, not magic dust. It's not a magic bullet. It's not a magic pill, but it is a way to challenge your musculoskeletal system and the biology of the body to really sort of mobilize your bone cells, your muscle cells, your stem cells in the right direction and to sort of suppress them going down the wrong path.
just thinking forward, I mean, a lot of people who have osteoporosis and issues with their bones have joint replacements. Is there any contraindication for using LIV with joint replacements?
Right. It's a great question, one that I'm often asked. So I used the word frail elderly before. We did a study in collaboration with Doug Keel at Harvard on a group of men and women that were average age of 84. So it sort of was 80 to 90 years old. And our exclusion criteria for the study when we went through the hospital review board was to avoid total hips and total knees because we didn't want to disrupt the process. But we found that age cohort, so many of them already have joints. So we went back to the hospital review board and said, sure, go ahead and do it because the signal is so small. And again, going back to my flag that we had no adverse events, so there was no downside to it. But I will also say on the upside, that the very first paper we did with low intensity vibration was demonstrating that a bony implant adjacent to bone actually promoted bony ingrowth. So I'm not here to say that this will help total joint osseointegration or interdigitation and anchoring, but all of our data suggests that it would and certainly would do no harm. So I would say, and remember, Dave, just as you keep reminding me to emphasize, that the signal is essentially 40% of gravity or 30% of the impact of your heel as you're walking slowly. Right. So the orthopedic surgeon should understand that this is actually very safe. He or she is encouraging his patient to get up and be active as soon as possible. This is a great parallel strategy to ensure that your bone cell population, your stem cell population, does not go to sleep while you're recovering from surgery.
I mean, thinking forward on that, if let's say I'd broken my leg and we'd done the normal cast procedure, my leg is healed as far as the cast is concerned, would you see LIV as a beneficial thing to do in that situation to improve the strength of the bone around the break?
So bringing England into this discussion, I actually went to graduate school at the University of Bristol, and lovely place, long ago. But collaborations have persisted over the years, and with Alan Goodship, who's now at UCL, we did a study that showed that these signals, although they are far smaller than walking would cause that fracture callus to displace, we're able to show that low intensity vibration actually augments, builds up the callus, and accelerates the regenerate, the bone healing. So we showed that we could accelerate fracture healing. Then some colleagues in Hong Kong actually did it on femoral neck fractures in humans and showed that humans with femoral neck fracture staining device, their fractures healed more quickly. So I would say, in a long answer to your short question, it is certainly safe, but there may actually be an upside to it.
Okay. Is there, I'm thinking of post-surgery situations, is there any situation you wouldn't recommend LIV?
Well, with all things, it's critical that the family be involved in discussion, the physician and the surgeon all understand the nature of the signal. And I'm not there to sort of present my perspective on it. So this needs to be an educated decision that patients and physicians make. But again, with no serious adverse events, with everyone in the medical community understanding the importance of mechanical signals and activity to keeping the physiology of the human up as high as it can be. We're working quite a bit now with people in spinal cord injury world.
Okay.
That I would say, by the crystal ball, I would say that signs point to positive outweighing the consequences.
Well, that's great. I can see Leah's popped up. So I think we're going to get hit with some questions now.
Oh, and George too, I think.
George is back.
He's asleep. He looks asleep.
He's been loving it, and so have we. So thank you so much. We've covered a lot, so it's been amazing. Thank you. And I know that we've had lots of questions come through, so we're going to try and get through as many as we can. If possible, we can try and keep it to a minute a question, but I doubt we'll do it, but we can try. So my first question is, so we have lots of clients who are really active, do lots of exercise, but they still have osteoporosis. So in what way does LiV differ from exercise in that respect? Because LiV is stimulating them in a way that exercise is not.
Right, it's a great question. I wish I had the perfect answer to it. But remember, what Dave and I were talking about mesenchymal stem cells, and they are much more robust, sensitive, and the population is much greater in the young than the old. And by old, I mean 50, 60, 70, 80. And it basically, your marrow goes from being very red and blood engorged as young, and then sort of when you're sort of middle-aged, it becomes sort of yellow, a little bit fatty, and then as we get older and older, it becomes sort of gray and I won't say dead, but far less viable. So the problem with exercising when we are older is, even though the skeleton is still challenged by these mechanical signals, the cell population isn't there as much to respond. So even though we've talked mainly about stimulating the cells to grow bone and do the right thing, what we haven't talked about is using the mechanical signals to protect the marrow from becoming basically displaced by fat and to actually increasing stem cell numbers. So I would say that certainly exercise does that, but remember that what we believe we're doing in the lab, although we haven't studied, there's a paper that came out from the University of Pennsylvania that shows a benefit to the marrow in postmenopausal women, which is incredibly exciting. But what we think we're doing is we are putting a lot more mechanical information into a shorter period of time than somebody who is 50, 60, 70 might be exercising. So I would suggest, in my longer than 1 minute answer, sorry, Leah, that by standing on the device, you are basically saturating the system with mechanical information. And back to Dave's point about doing it twice per day, I would try standing on the LiV device when you wake up in the morning, you're brushing your teeth, an hour before you go out and exercise, because then your cell population might be even more responsive.
Brilliant, thank you. So to go on to quite a specific question that we've had through, so how beneficial or safe is it to use LiV with gluteal insertional tendinitis, if that's something that you know of, or any form of tendinitis? Very specific.
We have not, I cannot give you clinical outcomes on it because we as a lab have not studied it. I have tendinitis and I stand on a device and it brings me relief. I'm saying that anecdotally. I apologize to your audience for a very intelligent question that I just don't have an answer to. But I would say, and just as my wife comes up with anecdotal evidence of relief from knee pain, I don't know how it works. And we are actually doing a study with Oregon Health Sciences University now on cancer neuropathy. For some reason, these mechanical signals do provide some benefit to dealing with joint motion and joint pain. And I'm not sure I know how it happens. Sorry.
I'm interjecting, and with a layman's viewpoint, if we accept that the bone structure is a smart mechanism that responds to activities, then surely the muscles and the cartilage will quite likely respond in a similar manner.
Right, there's no question, particularly because they have the common stem cell, although with muscle mesenchymal stem cells, typically called satellite cells. We have studied cartilage because we did want to make sure that we weren't damaging cartilage. And we see it as actually an anabolic signal to articular cartilage. we have not studied tendon or ligament. I only have so many graduate students, and they yell at me all the time anyway. So lots of tissues out there.
Perfect, thank you. So I know that you spoke a little bit about transmissibility in terms of the signal. I suppose quite a specific question to do with leg length or sort of limb length discrepancies, whether using LIV would affect, both limbs in the same way if you have a discrepancy in length.
So thanks, Leah, and I appreciate the question. And I would guess that you, as you advise people interested in the LIV device, to read the manufacturer's recommendations, and that includes not wearing shoes, to wear socks on your feet, kind of thing. And the reason that we have said that, or the manufacturer says that, is that when you say it's okay to wear shoes, that means people wear stiletto heels, or they wear tennis shoes, or they wear crepe soles, or whatever. But if you have a leg length discrepancy, and again, the plate, just as bone is a smart material, the device is a smart device, and it senses how to deliver the signal, that I would suggest that those with leg length discrepancies, or those that wear orthotics, that within reason, you can wear those devices on the LIV device. And I will point out that we did this specifically in our study with kids with cerebral palsy, because there are a lot of sort of joint extension problems in some of these kids. And so to make sure that we deliver the signal, we have actually actively used orthotics as sort of wedges to make sure the transmission occurs. So even though the signal is quite small, and some people wonder, how could this device possibly be working? That once people understand what the signal is and what it's trying to deliver, they can actually sense that it is actually transmitting. So fair enough question. I don't have a perfect answer to it, other than it's okay to use orthotics within reason.
Perfect, thank you. So another question for you. So how does LIV influence B cells, and is it possible that LiV would protect against cancer? So I know that you've done some sort of cancer studies in the past, so if you could talk a bit about that, that would be brilliant.
Sure, I can. And whoever asked the question, you can come join my lab anytime you want. So when we started the study on kids, this is done in collaboration with Curie Ness down at St. Jude's Children's Hospital in Memphis, we first had to demonstrate to the hospital review board, because you're taking sick children and you're putting on a device that you say is anabolic, or it's producing bone. And the last thing in the world you want to do with a sick kid is to actually activate the disease. So before we were able to actually study kids, we had to demonstrate it was safe to those that actually had an active cancer. So in order to do that, we actually used animal models of cancer. We looked both at ovarian cancer and multiple myeloma as cancers. And we're actually about to publish a study on a mouse model of breast cancer to show that we don't exacerbate the disease, but we do protect the skeleton. So as it turns out, we also, because we're curious scientists, we looked at the progression of the tumor, and in no way am I sitting here saying this is some magic approach to preventing or treating cancer. But my colleagues who are oncologists would certainly encourage that exercise is good for you. So we study how mechanical signals suppress cancer. That's going in a different direction a little bit than the viewer's question, which are B and T cells. So it turns out that all cells in your body, every one of them, whether they're touch corpuscles or whether they're the way that we hear or feel, they're all sensitive to mechanical signals and to vibration. The whole universe vibrates. I don't want to get corny here, but that's basically everything in the electromagnetic spectrum is vibration. So B and T cells do as well. And maybe some of your viewers have heard of CAR T, or autologous cell therapy, where people that are facing really nasty cancers have their own cells taken out, they're engineered and put back in to target a cancer. The problem is you can't get the T and the B cells to expand or proliferate. What are we doing in the lab right at the very second is we have T cells in the incubator that we buzz or that we vibrate with these exceedingly small signals. And the T cells go crazy. So just as Dave has challenged me to talk about bone cells going to sleep or being couch potatoes, your immune system does as well. And this is why if any reviewers go away with any message that exercise is good, all your physiologic systems, including cognition, right? Exercise is good for the brain. It's good for blood flow. It's good for bone and muscle. It's good for cartilage. It's good for your immune system. And we have done a preclinical, a mouse study on B and T cells showing that we can suppress diabetes and improve B and T cell counts by standing on the device. So it's not a primary outcome of what we do. And we've gotten into the cancer world studying it because we want to help kids grow their bone back as they recover from illness. But it turns out that we are now neck deep in studying cancer because of trying to study bone in kids.
Amazing. Yeah, I love how many applications there seem to be. Vibration is everywhere. It's incredible.
Vibration, you can't avoid it. Yes, you cannot avoid it.